All right. Good morning, everyone. My name is Sarah Thornton. I'm a cardiologist at UW, and it's my honor and privilege to get to introduce our Grand Round speakers this morning. So I'm going to start first with my colleague, Dr. Allexa Licon. She's a clinical assistant professor in the Department of Medicine in the Division of Cardiovascular Medicine. Dr. Licon received her undergraduate degree in biochemistry and cell biology from Rice University in Houston, before completing her medical school at Baylor and going on to complete her residency in internal medicine at UT Southwestern in Dallas. She then moved north to complete her cardiovascular disease fellowship at the University of Pittsburgh Medical Center before joining us in the division in 2022. Since 2022, she has been an invaluable colleague with a strong interest in cardio obstetrics, providing care to those who are at risk for developing cardiac conditions or have cardiovascular conditions through preconception, pregnancy, or postpartum period. She's been instrumental in our effort to start the combined cardiovascular OB clinic at UW, and she is the new primary investigator for the NHLBI-sponsored trial Rebirth, which will evaluate bromocriptine plus standard therapy versus standard therapy in the treatment of acute peripartum cardiomyopathy. I feel very lucky to call her a colleague in the division and can't wait to hear her today. Next, I also feel very lucky to introduce my colleague, Dr. Kara Hoppe. Dr. Hoppe is a distinguished maternal fetal medicine specialist and associate professor at UW Health with a focus on advancing care and health equity for pregnant persons. Her research has focused specifically on hypertension during pregnancy and the postpartum. Since joining UW in 2015, Dr. Hoppe has integrated her clinical practice, research, and leadership to drive innovation in maternal health. Her truly groundbreaking work includes the development of the Staying Healthy After Childbirth, or STAC program, which uses remote patient monitoring for hypertension postpartum and allows early detection and treatment of increasing blood pressures. Dr. Hoppe's research has significantly impacted guidelines for managing hypertension during pregnancy and has garnered national attention, for which I can attest to. As a leader, she's been instrumental in enhancing the research infrastructure, fostering interdisciplinary and community healthcare collaborations, and mentoring the next generation of researchers. She has also been instrumental in the push to get CV-OB clinics started here at UW. Her dedication extends to providing personalized clinical care and enhancing cardiovascular health during pregnancy. Her future goals include establishing a clinical research center of excellence and the Cardio Obstetrics Clinic to further advance maternal and cardiovascular health. She's very excited for the new core research project with the Prevention Research Center that will focus on dissemination of her work done through STAC, through a community-engaged approach to improve hypertension control among Black women and birthing people. So again, it's my honor today to introduce Dr. Hoppe and Dr. Licon, talking about pregnancy's silent echo, hypertensive disorders, and atherosclerotic heart disease. Go for it, ladies.
Thank you so much, Dr. Thornton, for the very warm introduction, and thank you so much for the invitation to present what we feel is such an important subject. And again, thank you so much for giving us an hour to discuss with our audience today. Dr. Hoppe, speaking on her behalf, does not have any relevant financial relationships with ineligible companies to disclose, neither do I. We do not intend to discuss any unlabeled or unapproved uses of drugs, devices in the presentation. And we'll get started. So 3 learning objectives today, at minimum, but hopefully we can at least get 3 accomplished today. So the first one will define cardiobstetrics as a subspecialty and explain why the field of cardiobstetrics is important in supporting favorable maternal outcomes. Second objective, we'll discuss how to effectively manage hypertensive disorders of pregnancy and how to counsel affected individuals and their subsequent increased risk for developing atherosclerotic cardiovascular disease in the future. And last but definitely not least, we will illustrate the importance of longitudinal follow-up with a primary care provider for individuals who suffered from hypertensive disorders of pregnancy. But again, hopefully we can have many more learning objectives accomplished during our time together. So just as a preface, cardiovascular disease is the leading cause of death for women, and this has been the case for some time now. Despite recent declines in cardiovascular mortality in women over the past decade, it still remains cardiovascular disease remains the number one killer for women. Deaths attributable to cardiovascular disease outnumber the deaths attributable to breast, ovarian, uterine, cervical, or vaginal cancers or childbirth combined. Cardiobstetrics. So of course, we want to give you an overview. This is a relatively new, formally recognized field, though this subspecialty has been around informally for decades and decades. But just as we're starting to gain momentum in kind of sharing our knowledge and the importance of having a cardiobstetrics field, wanted to share with you the consensus and what we do. So it's a subspecialty within cardiovascular medicine, prioritizing the care of individuals with cardiovascular risk factors or known cardiovascular conditions throughout their preconception, pregnancy, and postpartum journeys. And I have this nice figure down below by Dr. Davis, really just pointing out that fact. We really start seeing these patients in the preconception period for various cardiovascular conditions such as chronic hypertension, give them counseling, risk assessment, and then making sure that they are on the right medications and they are optimized as much as possible to proceed with the pregnancy. And then, of course, we continue to follow these individuals through their pregnancy, making sure they're still compensated from their chronic cardiovascular condition. And then, of course, labor and delivery, helping guide care through that phase in their pregnancy journey. And then, of course, in the postpartum, and we'll talk about postpartum, the fourth trimester, specifically for hypertension. But you'll see the points down below that we also tend to discuss with our patients. Wanted to bring this slide to everyone's attention, even though we say cardiobstetrics, meaning, of course, there's two subspecialties or specialties that are within the word cardiology and obstetrics, but it really does include so many other subspecialties and providers from different fields. It really does take a village in making sure that we can optimize maternal outcomes for every patient that comes into our office. And it's not just a cardiologist or an obstetrician. This figure points to that fact well. So in addition to OB and MFM, cardiology, there's other specialties within cardiology that are also very commonly involved in patients' care. Nursing, pharmacy, social work, anesthesiology, and of course, primary care have very essential roles to play in helping to make sure our patients get the best care possible in a vulnerable time. So why is cardiobstetrics important, and why has it become much more recognized as a field in the past few years? So unfortunately, this is both from the Commonwealth Fund figure to the left and the CDC figure to the right. So despite the United States being one of the highest GDP countries in the world, unfortunately, we have the highest maternal mortality rate out of all other high income countries, as the figure to the left highlights. And not only that, which I'll get into in a moment, but health disparities and cardiovascular outcomes, maternal outcomes are present. So I'm not sure. So the bar second to the right, you'll see the US population. And then, for example, the bar farthest to the right, you'll see the US Black population. And unfortunately, this group of people does have the highest risk for maternal mortality in our country. The CDC data here figured to the right. So we've had a rising maternal mortality rate for decades now, since the 1980s. And then you can see a high uptick in those maternal mortality, pregnancy-related mortality ratio in the last couple years even. So it is something that we, unfortunately, there's no plateau that we're seeing in our maternal mortality rates to date. And we need to really start appreciating why that's the case and how to prevent those deaths. So again, from the CDC, I like these figures. It highlights exactly the causes of maternal deaths in our country, in the United States. And so the figure to the left has years 2017 um, through 2019. And you can see there's some variability in the leading causes for maternal mortality um, uh, based on their data. But I put in the little heart symbols by the cardiovascular conditions that contribute to maternal deaths. And you can see here clearly that hypertensive disorders of pregnancy, cardiomyopathy, even thromboembolic disorders that we see, such as a pulmonary embolism, uh, are definitely uh, major contributors to the maternal mortality rate that we see. So certainly as cardiologists, we see many of these cardiovascular conditions outside of pregnancy. So it's not too surprising to see that we see similar conditions in pregnancy and postpartum. And so this is based off of the maternal mortality review teams. 4 in 5 pregnancy-related deaths that we see in the United States are thought to be preventable. So maternal mortality review teams is sponsored by the CDC. Um, Nationwide, each state has a maternal mortality review team, and we go through cases that in which a individual died essentially during their pregnancy or postpartum period. And the purpose of our team is to, one, figure out if this is a pregnancy related death or is it pregnancy associated, and two, and if it is pregnancy related, do we think that this could be preventable? Um, I have the pleasure of being part of the maternal mortality review team in Wisconsin, and the outcomes that we review are published um, routinely. So, and part of that, the published data that we see leads to this finding. Again, just that similar to what we see nationwide, 4 in 5 pregnancy-related deaths are thought to be preventable. So, these types of workforce groups are going to be very important and paramount in helping us better understand what's contributing to the maternal mortality rate and how can we um, lower the maternal mortality rate and prevent these deaths from occurring. So, what contributes to cardiovascular deaths among pregnant women? Pregnant women with high blood pressure have twice the risk of developing heart disease later in life compared to pregnant women without this condition. In the United States, high blood pressure develops in 1 in every 8 pregnancies. That's 13%. And looking at in our own neighborhood, in Wisconsin, high blood pressure develops in 1 in every 3 to 5% of pregnancies, which is 25 to 30%. So there's a much higher rate in Wisconsin. More than 1 in 4 of pregnancy-related deaths in the United States were due to heart disease and stroke, and only 6% of these women had a previous diagnosis of a heart condition. In terms of pregnancy-related deaths, again in Wisconsin, this is based off of data that was published data in 2020. Cardiovascular conditions that we define as conditions affecting the heart or blood vessels, excluding cardiomyopathy in this case, and hypertensive disorders, which we'll get into much more discussion during our talk today. That includes high blood pressure like preeclampsia, eclampsia, or chronic hypertension. So 29% of all pregnancy-related deaths in 2020 were caused by cardiovascular conditions or hypertensive disorders, not an insignificant number. And other related outcomes, 48 people experienced severe cardiac complications during delivery in 2020. This includes non-fatal cardiac complications. And then a little over 7,000 people had a hypertensive disorder during pregnancy or at delivery in 2020. And again, this is based off of what I was just commenting about a couple minutes ago. This is the published information that we acquired through reviewing these cases in our Wisconsin maternal mortality review team. So I can't discuss an overview of cardiobstetrics without highlighting the health disparities that exist in maternal cardiovascular outcomes, and therefore really emphasizing the need for this field. So again, this is the CDC data we're highlighting in this slide. So in 2020, Black women continued to have the highest mortality rates. So that's 55.3 per 100,000 live births. And this rate is 2.9 times the rate for non-Hispanic white women. The rise in maternal mortality rate between 2019 and 2020 was found to be significant for non-Hispanic Black and Hispanic women, but that wasn't really seen in white women. It actually was not found to be statistically significant, though there was also a rise in the maternal mortality rate in this group as well. And so this figure to the right kind of highlights that point between 2018 and 2020. You can see that there, no matter the group, there is a rise in the maternal mortality rate between 2018 and 2020. But unfortunately, non-Hispanic Black women tend to have they do have the highest rate in maternal mortality in this country. So again, going back to Wisconsin, what does it look like in our own state, in our own neighborhood? This is through the Wisconsin Department of Health Services. So between 2006 and 2010, going to the national data first as a comparison. So 16 maternal deaths per 100,000 live births were seen in the United States. The number of maternal deaths per 100,000 live births was 3.2 times greater in non-Hispanic Black women than non-Hispanic white women. Looking at Wisconsin, you know, if you read this first line alone, you would think, well, this is great. So 5.9 maternal deaths per 100,000 live births in Wisconsin, much lower than the national average. However, this is where we see the disparity. Number of maternal deaths per 100,000 live births was 5 times greater in non-Hispanic Black women than non-Hispanic white women. So why is that the case? Nationally, we see 3.2 times greater for Black women to suffer from a maternal deaths than non-Hispanic white women. In Wisconsin, is 5 times greater. So there's a lot of unanswered questions in this regard. We do have some leading hypotheses and consensus into partial contributors to why we're seeing this. But again, this disparity is alarming in cardiovascular outcomes. In 2016 to 2017, the Wisconsin Maternal Mortality Report showed that while non-Hispanic, Black, non-Hispanic, Asian, and Hispanic mothers made up only a quarter of Wisconsin births, and this was between 2016 and 2017, they represented nearly 1/2 of all pregnancy-related deaths in the same period. So it's highlighting the same thing. You know, why are we seeing overrepresentation of maternal deaths in patient populations that are considered traditionally vulnerable populations in our community? So this is a study that I thought would be nice to include in this presentation, again, highlighting the point. You can hear what I have to say, but of course, it's always nice to get some objective data to kind of better understand what we're talking about here. So this was a study uh, looking at the incidence of preeclampsia between different patient populations and if maternal cardiovascular outcomes would differ depending on socioeconomic class. So this is a title, Racial and Socioeconomic Disparities in Cardiovascular Outcomes, and this was between 2004 and 2019, published in JACC in 2022, retrospective study. So the patient sample was acquired through reviewing the national inpatient sample. There's 47 participating states, including District of Columbia. They used ICD codes for retrieval of their data that was needed for the study. The primary study endpoint was inpatient mortality. The secondary endpoints, I won't list them all, but they're included below. Includes things like peripartum cardiomyopathy, acute coronary syndrome, acute kidney injury, stroke, etc. All right, so 2.4 million people were included in this study. 43% were white, 18% were Black, 18% were Hispanic, and 3% were Asian Pacific Islander. And these groups are stratified based on median household income. So you can see, again, in the time period that they studied this patient population, preeclampsia for low income group would be the figure to the right, figure to the left. And you can see the red bars would be corresponding to Black population. Blue bar would be white, green Hispanic, brown would be Hispanic and green would be Asian Pacific Islander. No matter the year, you can see that the Black patient population was the highest for preeclampsia in the low income group. And then if you can glance over to the figure to the right too, it's the same for the high income socioeconomic group as well. Black people did have preeclampsia, the highest rate of preeclampsia. Um, so just highlighting that fact, we can go to the next slide. And then in terms of the results, so looking at differences in cardiovascular outcomes between various groups. So increased in-hospital mortality was seen in Black, Hispanic, and Asian Pacific Islander groups compared to white women, no matter the income group. Black women had higher odds of cardiovascular complications compared to white women of their corresponding income class. Higher rates of cardiovascular complications were seen in high-income Black women compared to low-income white women, which I'll take a minute to just kind of reflect on that because that's pretty astounding to note that kind of difference. So socioeconomic status, though, historically has been considered a possible contributor to the health disparities that were and outcomes that we're seeing, at least in this study. They did not find that to be as much of the case. White women from higher income strata had better outcomes, such as mortality, cardiovascular complications, compared with white women from lower income groups. But this was not observed in Black women. So again, highlighting there must be more to the story than differences in socioeconomic status contributing to our maternal outcomes. So in fact, Black women were found to have higher odds of acute coronary syndrome and acute kidney injury. And so that's essentially what this figure to the right is highlighting. They had a really nice figure kind of explaining all of their findings here. So to the left, you'll see high income versus low income in both white and Black women. For white women, kind of as we would logically think, for higher income white women, they tend to have a reduction in their cardiovascular complication outcome. And then for Black women, though, we're not seeing that. And actually in the higher income group, for reasons unknown, we're seeing actually Black women suffered from more cardiovascular complications than lower income Black women. And then the figure to the right, comparing high income Black women to low income white women. Almost across the board, we're seeing an increase in cardiovascular complications in Black women in the high income group compared to white women in the low income group. So before I go into this, I kind of touched on the reasons for why we're seeing these disparities in cardiovascular outcomes are unclear, but I do want to make sure that I highlight an important contributor would be healthcare bias and bias in the healthcare system. Um, uh, Very complicated in the context of our history as a nation that leads to the different um, contributors to poorer outcomes in traditionally vulnerable communities. But again, more research and more studies will be needed to kind of figure out what other contributors exist and how we can actually actively engage ourselves within the healthcare system and community to make a change in reducing this risk for disparities in outcomes. So the case for building a cardiobstetrics program, again, highlighting just that, more research is needed, more education is needed. This program, cardiobstetrics program, has become more highly favored nationally to become established at academic institutions and can serve as a catalyst for positively impacting the delivery of maternal health care. As I mentioned, prioritizing research, education, guideline-directed clinical care. This is a growing field, but we are having more and more information available to us. And so there's becoming more of a consensus in how we can best manage our patients with cardiovascular conditions, expanding our fund of knowledge, providing multidisciplinary educational resources and clinical experiences for medical trainees and anyone who is interested in learning more about cardiobstetrics, which I can hope to convince our audience here today by the end of this talk. Hopefully everyone will be interested. And then research endeavors to address the still many unanswered questions. Hopefully, community outreach initiatives would be very helpful in serving as a bridge to our community. And from an educational standpoint, health fairs, educational seminars, and equality improvement will be key as well. Advocating for the patients we treat is the bottom line. A lot of these patients, unfortunately, are more vulnerable because historically symptoms for lack of a better word, a lot of the patients don't have the appropriate attention given to them in their pregnancy and postpartum period, and that often leads to a delay in their diagnosis and again a poorer outcome. So we need to advocate for these patients that are highest risk for maternal complications. So briefly, just highlighting the point, the need for a cardiobstetrics program. This was published in JACC by Dr. Bello. It was a survey sent to various providers in cardiovascular medicine, including fellows, attendings, and healthcare team members, advanced APPs, PAs. And what they found essentially is what we expected. So there wasn't really much comfort amongst providers in managing patients who are pregnant or postpartum. The group of individuals that had the highest level of feeling comfortable were the attendings, but again, it's not as confident in managing these patients as we would hope. And then for the lowest level of comfortability of managing these patients were found to be in the CV care team members, and that was included as APPs, PAs, nurses, etc. And again, so just highlighting the same point, we don't have to belabor this too much, but just really highlighting the need that more education would be helpful, both from a training perspective, as you know, we're starting to continuing to train future attendings who might one day be in their own private practice and not have the resources that they could otherwise have had the opportunity to uh, take advantage of in cardiobstetrics training. And then for attendings as well, this might be helpful for attendings at academic institution to have exposure to a cardiobstetrics program so that they themselves can learn more about how to best care for these individuals, and also have a referral center in place so that these patients do get the appropriate care. We can skip this slide. So this is again highlighting the point. And then before I hand off to Dr. Hoppe, so this is another study that was done looking at a cardiobstetric center at Columbia and seeing if outcomes would change based on their multidisciplinary care given. So the median CARPEX score, which we'll talk about at the end, but this is a risk assessment stratification tool that we use to help determine risk for cardiovascular complications in pregnancy. 3 is equivalent to a 15% predicted primary cardiac event during pregnancy, so it's not insignificant. So this is a pretty complicated patient population that they were treating. Primary outcome that they looked for was cardiovascular readmission at 30, 90, and 365 days. And then I'll just go to the bottom line here, since this will be the last slide here. Bottom line would be readmission rates were found to be actually low. And actually the cardiovascular complication rate was found to be lower than the estimated risk based on the CARPEG score. So wondering if having multidisciplinary care through a cardio-B clinic did serve to be favorable in reducing the risk for those outcomes. And then finally, here's our cardiobstetrics team that we have recently established here at UW formally. So we have our cardiology providers to the left here, and our OB MFM provider, OB team to the right here. And so we're very excited to continue our efforts to build this program formally. And as Dr. Thorson mentioned at the beginning, we're currently in process of trying to build a multidisciplinary cardio B space here at UW Meriter as well.
All right, so I'm going to take over from here for a little bit, focus more on the obstetric space, and we're going to kick things off with a case, and we will be referring to this patient as AG. So AG is a 33-year-old G2P010, which means she's had 2 pregnancies and 1 preterm birth, and she's about 8 weeks gestation. Pretty complicated medical history, significant for anxiety, depression, uncontrolled type 2 diabetes. Her history has been complicated by history of osteomyelitis, requiring a right lower extremity amputation, peripheral artery disease, status post-ephemeral angioplasty. She has moderate left ventricular hypertrophy and heart failure with preserved ejection fraction, or HFpEF, as well as chronic hypertension. She is presenting to her OB to establish care and had previously been taking metoprolol, irbesartan, hydrochlorothiazide, and amlodipine, with blood pressures still above goal. Because these are not favored medications in pregnancy, she was switched to nifedipine extended release 90 milligrams daily and labetalol 100 milligrams twice daily when she learned she was pregnant. She's continuing to have high blood pressure above systolics of the 150s and diastolics in the upper 90s. This is just a brief listing of how we classify hypertensive disorders of pregnancy. And so we have gestational hypertension, preeclampsia with or without severe features, eclampsia, chronic hypertension or pre-existing hypertension, and then folks who get preeclampsia with chronic hypertension we call superimposed preeclampsia. This here breaks it out with definitions more, and I don't want to get too caught in the weeds here, but some unique things to think about. The overarching umbrella term is hypertensive disorders of pregnancy. Chronic hypertension, we classify if somebody has known or pre-existing hypertension before 20 weeks of pregnancy. Pre-existing anytime in the pregnancy, but also anybody who develops hypertension before 20 weeks, we will classify them as chronic within the pregnancy. It would be very unlikely for somebody to get gestational or preeclampsia before 20 weeks. So then the rest of the conditions that are more pregnancy related would be classified either as gestational hypertension, which is just new onset of hypertension after the 20 weeks without any end organ evidence of effect, and then they don't spill proteinuria. And then preeclampsia, again, is hypertension after 20 weeks. However, they have proteinuria or other kind of end organ sequelae, like changes in their blood counts, like specifically platelets in their kidney or liver, pulmonary edema, or neurologic sequelae. And then we have superimposed preeclampsia, which would be again on top of chronic, and we also have eclampsia, which is a seizure on top of these conditions. So this slide here is a nice table to just show how the latest guidelines from 2019 American College of Obstetricians and Gynecologists compare to the American College of Cardiology and American Heart Association guidelines regarding hypertension. What you can see is that ACOG defines normal blood pressures of anything less than 140/90. American College of Cardiology and AHA would classify normal as anything less than 120/80. Regarding chronic hypertension, so again, if we're classifying in the OBGYN world, anything less than 140/90 normal, it gives this conundrum of what do we do with the reclassified stage 1 hypertension, which is, as you can see, anything between 130 to 139/80 to 90. So kind of in the ACOG guidelines, we focus on blood pressure management with higher thresholds of blood pressure. And it leaves us this conundrum of that stage 1 classification. And so we don't really have great consensus of treatment in that threshold. And again, just to call out that it can be confusing for providers and patients if they know that they have been classified and then they're no longer classified in pregnancy. So some work to do in that space. And us as a group here, we acknowledge the stage 1 hypertension, and we will manage them as such throughout their pregnancy. This is work that my group has done, which is leveraged out of our postpartum hypertension program. When I started in this space as a physician scientist back in 2015, and trying to figure out, how to optimize care for people. There was really a paucity of data on what do blood pressures even do throughout pregnancy and postpartum, specifically postpartum. And really at that time, the best data we had was just a few hundred patients, in the first week postpartum. So we were able to take, patients who were participating in a remote monitoring program. And in this particular cohort, it's about 900 patients, and then look back retrospectively at their pregnancy. And so I'll focus mostly on the figure on the left here, but you can see the very first dot is pre-pregnancy. And then the top line is systolic blood pressures, and the third line down are the diastolic blood pressures. But what you can see is the blood pressures do drop in the early part of pregnancy. And so this creates an issue where a lot of people will present at that time, and then their hypertension is again missed because they're normotensive, or they think they're cured because their blood pressures are better than they've ever been. So those next three dots are the first, second, and third trimester. And then I know it's small, but the D, or the first peak you see, is the day of delivery. So blood pressures do naturally rise throughout the pregnancy and often peak at the time of delivery. And then you see a drop again. And again, those are the first few days postpartum. And so people are discharged, again, thinking, in parentheses, they're cured, or there's not going to be any problems. But what we've learned is that in the first week postpartum, there's a lot of blood pressure spikings or increases. And those most commonly happen between days 4 to 7 postpartum. Again, probably a reason why we're seeing some of the morbid cardiovascular events that we're seeing, because these people are discharged, they're at home, and they're not typically monitored closely. And then, as you can appreciate, those blood pressures will get better most of the time throughout those first 2 weeks postpartum. In our cohort, we did still see, though, at 6 weeks postpartum, at least 30% of patients still requiring blood pressure medications to control their blood pressures. So just to briefly talk about symptoms of preeclampsia, the top left box, the most common symptom is nothing. And so it can be pretty tricky. A lot of this is picked up on routine clinic care visits. And by the time people are coming in with the rest of these symptoms, their disease process can be quite advanced. But it is really important to educate people on if they feel any of these symptoms to present. But there, like I said, can be a lot of people with very severe hypertension and really have no symptoms. This is a nice summary of the prenatal to the kind of long-term lens regarding maternal hypertension. So in the prenatal space, we can have a lot of adverse pregnancy outcomes, including placental abruption, where the placenta detaches from the uterine wall and you can have vaginal bleeding. And in severe cases, maternal or fetal compromise or death. Preterm birth, low birth weight, and as I just sort of mentioned, fetal or neonatal demise. In the postpartum period, one of the common reasons for neonatal or NICU admissions is hypertension disorders, as they contribute to a lot of our preterm births, maternal hemorrhage, stroke, maternal infant death, and adverse cardiac events. And then long term, it's really important for people to understand that when they've had an event like this in pregnancy, they are at long-term risk of chronic hypertension, cardiovascular disease, and cardiovascular-related mortality. I want to talk a little bit about the CHAP trial. So this was a pretty outstanding trial that took many years to complete. But, thinking back from my training and probably many people here, we really didn't know what was the right threshold to treat chronic hypertension in pregnancy. And I was taught, stop medications and not treat until 160 over 110. And I think everyone on this webinar today will recognize that you would not let a normal non-pregnant person have blood pressures that high. So the purpose of this trial was to evaluate the benefits and safety of antihypertensive therapy for mild chronic hypertension during pregnancy. And again, we have sort of some interesting thresholds and kind of how we classify things, but mild to us is anything ranging from systolic of 140 to 160 over diastolics of 90 to 110. For this trial, the top diastolic number was 105. So what we did is we compared standard treatment, which again I mentioned was not treating people's hypertension until they achieved a blood pressure of 160 over 105, compared to an active treatment arm where they had treatment when they achieved 140 over 90, or they came into the pregnancy on antihypertensive medication. So we wouldn't stop those medications, or we would start them at that lower threshold. The primary outcome for this study was actually a composite. So it included preeclampsia severe features, medically indicated preterm birth before 35 weeks, placental abruption, or a fetal or neonatal death. And there was a secondary safety outcome of small for gestational age infants, because again, historically, one of the reasons not to treat until that higher threshold was that they were worried we would make the baby small. So the results of this trial demonstrated that treatment of chronic hypertension to blood pressures less than 140/90 decreased the adverse maternal primary outcome, and the number needed to treat was just 14. We also found out that treatment at this lower threshold did not impair fetal growth, and there were no other maternal or perinatal harms. So the kind of main results were that CHAP supported treating chronic hypertension to blood pressures less than 140/90 in pregnancy. If people approach you early in the pregnancy, continue them on their medications. There's no evidence to stop them at this time. And then long-term studies are ongoing. So we have a maternal follow-up study as well as a childhood follow-up study ongoing. And it was a pretty amazing trial to see that the overnight response to dissemination and really getting providers on board nationally to really more aggressively treat patients with chronic hypertension. The CDC, as well as many other organizations, including, for example, like Million Hearts, AAFP, ACOG, AMA, Society of Maternal Fetal Medicine, all work together to put out a hypertension and pregnancy change package document. And so this is a great resource for people to look at. And they have recommendations really from the patient all the way up to the systems level, as well as many tools that can be used within people's practices, et cetera. But this is one table from there that lists preferred medications in pregnancy as well as lactation. And so you can see this top box here. Again, our go-to medication first-line agents would be labetalol, nifedipine, and methyl-dopa continues to be listed, but really nobody's using it anymore. And then second-line agents, hydralazine, chlorothalidone, hydrochlorothiazide, and clonidine. The preferred agents used in the CHAP trial were labetalol, nifedipine, actually given to patients for free. And it was pragmatic, so providers could decide which one to use, but they did over time allow for any meds to be used that would be in this box on that trial. So as we think about the patient we started with, AG, so her blood pressures were persistently above goal, kind of always. Nifedipine at one point around 12 weeks was increased to 90 milligrams daily. Sorry, increased from 90 milligrams daily to 60 milligrams twice daily. We often will use nifedipine, even though it's an extended release drug, twice daily. The thought being that the renal clearance goes up and that the medication works better split in two. The labetalol ended up being discontinued because she thought it made her nauseous, and she was started on hydralazine. She also was started on aspirin at 12 weeks to lower the risk of developing preeclampsia. We typically tell people to start this between 12 and 16 weeks. Why does it work? We don't totally know, but we think it has something to do with improving the placental implantation. We think the placental implantation and interface has a lot to do with development of preeclampsia. So that is one thing we have, and really the only thing we have to try to help reduce preeclampsia at this time. This is a summary table here that helps you understand who we would recommend giving aspirin to. So anyone with the high-risk features on the top, and then anybody who has two or more of the following moderate risk factors would be also recommended to take aspirin. What dose do we recommend? So most people are probably pretty familiar with the recommended 81 milligram dosing. Turns out most of the world is using 150 milligrams. And here in the US, our guidelines really still suggest 81 milligrams. Whether that's just delay in dissemination of results or we don't truly have the right dose figured out. Our group did a systematic review and reviewed around 1,600 articles, 23 randomized trials with over 32,000 women. And what we found was that specifically with preterm preeclampsia, women who had 150 milligrams or more had a really significant reduction in their risk of preterm preeclampsia, specifically at 62%. And then what we found when you clustered up aspirin doses of less than 150 milligrams, that dose didn't alter the preterm preeclampsia risk. And so our group has made the decision to use that higher dose, again, to hopefully have a more robust reduction in the preterm preeclampsia, which again, has more downstream sequelae, for example, preterm births and whatnot. The number needed to treat if we used 150 milligram aspirin doses was 39 to reduce 1 case of preeclampsia. And then the overall risk reduction in preeclampsia with aspirin, kind of at any dose for all gestational ages, is about 30%. And then to the right, you can see the forest plot for that. The other thing to know is that in the US, we don't have 150 milligram formulation, so we recommend 2 baby aspirins or 162 milligrams. So again, back to AG, she really was not able to control her blood pressures throughout her pregnancy. At a routine OB visit at 28 weeks, she was found to have blood pressure readings that were considered severe. She did have a headache, and she was sent for further evaluation in our obstetrical triage department. She was diagnosed with chronic hypertension and superimposed preeclampsia. We use a medication called IV magnesium to prevent seizures. So she was started on that. Her medications were adjusted again. However, we were not able to control her blood pressure. So in this sort of acute severe hypertension phase of pregnancy, we don't typically go beyond 2 medications. We'll typically uptitrate nifedipine and labetalol. Sometimes diuretics are used, but once we reach that threshold, typically delivery is recommended. This patient had a failure of induction of labor and ended up having a C-section at 28 weeks, 5 days gestation. And then postpartum blood pressures were really difficult to control. So we do have patients who will be discharged on an extraordinary amount of medications. We do a really good job with our home monitoring program. And so we take all comers in this program. And she was discharged on enalapril, hydrochlorothiazide, nifedipine, and labetalol. Again, back to this table, we have down on the bottom, here's some preferred medications for lactation, where to start the doses and maximum doses, and what precautions to consider. We will add in ACE inhibitors commonly in that postpartum period. The one that supposedly has the least excretion in the milk is captopril, but it's dosed really frequently, and so we'll often use enalapril and less likely lisinopril. Lisinopril is thought to have the most concentration in the breast milk. We'll also use labetalol and hydrochlorothiazide and hydralazine. This is a really nice table. This document, as you can see down in the bottom right, I have the screen cover of it, but it was put out by American College of Cardiology, and it's specifically the Postpartum Hypertension Clinic Development Toolkit. But this table is really nice. So here's a reference for people. First line agents, again, on the left. A lot of programs across the country are using amlodipine. It's a once daily dosing, and seems to be kind of longer acting than nifedipine, and so that can be a really good agent to consider as well. And then a lot more permission of alternative use agents listed below. So I think the takeaway here is we need to treat people's hypertension and need to make sure people feel safe and understand that it is safe to take these for their safety and not to avoid them because they're concerned about their baby. The far right has some lactation safety data with the ones in the blue being the lowest relative doses in the breast milk. But we have patients, who will take all of these when indicated. Not all of them at once, obviously, but any one of these. Another thing to know about is self-measured blood pressure or remote patient monitoring. I feel like in the world of medicine and cardiology, we hear more about self-measured blood pressures as a tool being used for non-adult patients. in clinic and looking at, making sure people have diagnosed chronic hypertension and optimal control, etc. However, in our obstetric world and postpartum world, we tend to call it remote patient monitoring. There's a lot of groups trying to work on this, including us here. There's still a lot of gaps in our guidelines, though. Considering what we've done here, we started working on this back in 2016. Again, on the left, you can see on the bottom, hospital readmission rates were as high as 5% at that time. Across the country, they can be as high as 10% in many places. We started really small in 2016 with a feasibility project. We got a small foundation grant, 30 devices to send people home with, a 1.0 nurse split between 2 people to really monitor these people. We learned quickly we needed, a delegation protocol for monitoring people, how to treat their hypertension, how to keep people safe, how to, have rapid turnaround in responses. Again, uniquely in this population, as I mentioned, blood pressures can become problematic really quick. We did some trials along the way. We established a clinical program in 2019. We have over 90% engagement with all comers having hypertension discharging from the hospital, which is about 30% of our 5,000 births. We've taken care of over 8,000 patients, and we have a really low readmission rate. So as of 2024, that was 1.16. We're working more on disseminating this through communities at this time through a CDC grant. And as you see on the right, there's many people involved with these efforts, and it really takes a village. Just in the sake of time, I'm going to go through some of this stuff rather quick, but this was just one of our first trials that showed that we could significantly reduce hospital readmissions using a care model like this, as well as being able to acquire blood pressures within that first week. 94% of people in telehealth compared to standard outpatient care, meaning like people are supposed to come back to clinic in that first week postpartum, was about 60%. So opening up telehealth opportunities or remote monitoring solutions really allows people to have better engagement with their healthcare. And then just to mention, they really need us and use us. 6 out of 10 of our new moms participating in STAC do require medication initiation or increasing to adequately control their blood pressures in the first 6 weeks. And so it really is a very effective way to keep people safe. And also thinking about reducing morbidity and mortality, like we talked at the beginning of this talk. There's a lot of components to think about when you're thinking about a program like this. And so it's complicated, but we've been quite successful here, and happy to talk to anybody about it anytime on strategies to grow this. It's been really hard to grow throughout healthcare systems, but we're making progress, so it's good. Another issue to consider is validation of blood pressure devices in pregnancy. We have very few. It's complicated on how to get these through the FDA, and there's minimal incentive at this point really to get those through. And so very few devices are actually validated for pregnant patients, and that's a current gap. There's a couple resources on the bottom, Stride BP and Validate BP, that are good resources to look to see if you have a patient and you're looking to see what devices are validated for them. Regarding AG, she was in that program, through 6 weeks postpartum with adjustments, sometimes daily, to keep her blood pressures in control. It's really cool with the collaboration we have with the Cardio providers. I called Dr. Licon and was like, I have a problem. This patient's coming to clinic, her baby's in the NICU. Would you be willing to pop on a call with her? And so we were able to set it up, with our APP and her in the room together to really address the concerns with this patient, and really tailor her medications to try to keep her safe, and really to also introduce her to Dr. Licon to hopefully give a warm handoff and that transition of care, to continue to engage as time goes by. This person is so high risk and started high risk, had a preterm birth, and unfortunately has a really high risk of long-term cardiovascular issues. And so this really just hits home of why cardiobstetric collaboration is important. There's a lot of things to think about with transition of care. I mean, we have a dream of having a collaborative space for this. A lot of people are referred to their primary care clinician. Specialty clinics, I think, are more rare. It depends on the capacity and the local capacity. But again, we're trying to really create this space with hopefully a lot of different specialties involved someday. This is just a kind of comment that, we can keep people safe immediately in those first 6 weeks, but we do need a longitudinal care plan, and we really do need to help people engage through that first year and beyond with the goal of reducing, the overall cardiovascular risk. We just completed a study called Stack My Heartbeat. And for this project, we randomized people either to our home monitoring program or with or without health coaching and home blood pressure surveillance compared to standard care, which is, their care ends at 6 weeks postpartum with transition of care to a PCP. We're really excited to say we did increase our 12-month follow-up from 50% in the standard care arm to 81% in the intervention arm. And we have early data to suggest that the blood pressures are systolic and diastolic dropped at least 5 points, and control was significantly higher in the intervention group at 12 months. So more to come on this. It's not published yet, but we're super excited about the results. Things to think about in those follow-up care visits: really have symptoms resolved, are the blood pressures controlled, what are the regimens they're on, what adjustments should be made, contraceptive choice options, and then really counseling on future ASCVD risk. These are just some resources here for contraception. And I just want to mention, we really need to avoid estrogen and combined oral contraceptives for these patients, as it increases their risk of thrombotic events. Dr. Licon.
Thank you. And I'll really try to wrap this up because I know we're pushing time. So if I can, if there's one sentence I can say to bring the point home: twofold increased risk for people who had a hypertensive disorder pregnancy. So that's including preeclampsia, gestational hypertension, for having atherosclerotic cardiovascular disease down the road and at an earlier age compared to those that did not have those diagnoses. Next slide. So this just brings home the point again, a study, nice figures at the bottom. That's why I wanted to include this, but it's just reiterating earlier onset of atherosclerotic cardiovascular disease for those that have hypertensive disorders of pregnancy, twofold increased risk. Keep going there. Another study to confirm, there's plenty of studies out there that highlight the same point. So this is a different study, same principle, that they found the increased risk for cardiovascular disease in those with hypertensive disorders of pregnancy. You can keep going here. Keep going. Perfect. So what can be done to lower the risk of cardiovascular disease? A couple slides down the road, I'm going to talk about or just review a American Heart Association Life's Essential 8. And so we can see a lot of those essential practices that they recommend here. So traditional risk factors, quote unquote traditional, so stopping tobacco use, managing BMI, appropriate exercise, 150 minutes a week of moderate intensity physical activity, screening for and managing diabetes, high cholesterol, really focusing on blood pressure, because that is another increased risk for those with hypertensive disorders of pregnancy. They are also at increased risk for developing hypertension outside of their pregnancy, postpartum period, chronic hypertension. Okay. So I apologize. There's a debate whether or not we can use, not really a debate, so the 10-year estimated risk for atherosclerotic cardiovascular disease, we do like to incorporate when we can, but unfortunately the age cutoff is 40 years and older, so that often does not apply to our patient population. We're seeing them at like 20s, 30s. So, of course, with their 40 years and over, preeclampsia is now a risk enhancer that has been recognized by the ACC, AHA, and that has been included in the updated primary prevention guidelines. And for those with intermediate borderline risk for having cardiovascular disease in that 10-year risk, 10-year time period, would they benefit from a statin? So you can use that risk enhancer to help make that decision. But what if they're less than 40 years in our patient population? So what do we do? Unfortunately, the area is still gray. We can go into the next slide here. I'm not going to touch really much on this point, but it's really just highlighting there's not much information out there to help estimate our patients' personal risk for having cardiovascular disease if they've had a hypertensive disorder pregnancy, but we're working on it. This model had a modest modest performance in predicting risk, but the fact that it's published and there is a lot of efforts in this field is promising. Okay, so 1 year later, and this is going to the preconception period, she's on medications, blood pressure is well controlled. What do we do in this case when she's returning for preconception counseling? So again, is blood pressure well controlled? Does the patient have resistant hypertension? I would say in AG's case, that should definitely be something worth considering. She has not had a secondary workup before, so the figure to the right kind of highlights some of the secondary workup that we would typically perform for if indicated. And are they safe? Are these medications safe for use in pregnancy? CARPEG-2 and modified here, we can go to those slides, or it can just give us some basic risk assessment profiles for individual patients with certain cardiovascular conditions. Mentioned this briefly in the prior study that I commented on, but CARPEG-2 is a common one that we use. Modified WHO is another, so it can help with that shared decision making. And again, Life's Essential 8 for the next slide. For preconception counseling. So, in the primary care provider world, it's going to be really important to, for one, educate patients on their cardiovascular risk, what they can do to lessen the risk of cardiovascular disease, screening early for modifiable risk factors like diabetes, lipids, smoking, regular physical activity. Really promoting a heart healthy lifestyle to lessen that risk as much as we can. The more research is needed in order to help guide how often should we screen for these modifiable risk factors. Of course, blood pressure should be at least annually. Nice thing is that with each visit for most providers, they check a blood pressure. So that's a pretty easy tool that can be used. But screening for diabetes, cholesterol, smoking are going to be really important, and practicing Life's Essential 8. So we can go to the next slide here. This is just highlighting, it's a huge circle. So it's a reproductive cycle that we see people from preconception through postpartum and then back again to the preconception period. So this really is lifelong work that we need to highlight.
This was just to wrap things up here. So just a life course perspective of hypertensive disorders. We really need a wide lens, just as Dr. Licon said, preconception and beyond. We need to increase the rate of hypertension. The rate of hypertension is increasing. We need to work on controlling that hypertension in young people. How, we just talked about how it behaves in the postpartum period, but it will continue beyond their life and how we handle that. And then thinking about how we can be using SMBP and remote monitoring to keep people safe, not only immediately postpartum, but long term. And then just some key considerations here: increasing access to remote care, telehealth services, education, provider training, patient training, regulatory and institutional practices and policies to remove barriers. We're really working to make this a systems level kind of engagement to make things better across the board. We have resources here. I'll just screen through them, but we mentioned the change package, ACOG. Unfortunately, a lot of their documents you have to be a member to read. Hear Her campaign. There's a lot of stories to share with patients and hear attestations, but the CDC's done a lot of work to really raise awareness. Preeclampsia Foundation, and then the reproductive health and cardiobstetric kind of resources. Thank you. Sorry we went over a little bit, but we'll turn it back over to Sarah. It's been a pleasure.
Fantastic talk. We had a number of awesome questions, but due to time, I've whittled it down to one that I am very curious about too. So I'd like to get both of your opinions on this. So our listener writes, management of multifaceted health issues in at-risk populations requires proactive care coordination and strategies to sometimes bring the care to the patient, rather than depending on patients' secure transportation and arranged visits in the clinic. Telemedicine can be helpful, but may not be accessible for certain socioeconomic groups. Models for care in the community, for example, home-based primary care, exist. How does your team plan to bridge this challenge, especially in rural populations? So bringing care to rural populations through telemedicine or other care models.
Do you want to take that, Dr. Licon?
Sure. So I think, thank you for that question. It's an interesting one, and I think we need to be creative in how to access our patient populations that do not have, it's common for a lot of people not to have access to transportation to make their way to clinic. And then even in the early postpartum period, you just have a newborn, you are busy. I was just there myself, I get it. So we need to figure out creative solutions for those that cannot make their way to clinic. The traditional way. So telemedicine visits or virtual visits are amazing. I'm a huge advocate for that type of clinic visit for our patient population. Of course, would I prefer a face-to-face visit? Yes, but a great plan B are telemedicine or virtual visits. And if they do not have access to a means to a video visit, I've in the past, in fellowship, I've even done phone, whatever I can to talk to the patient, whatever I can do to talk to the patient. If I can't examine them, then I can at least, I ask them to even, if they have a phone to show me their legs, or, make sure they don't have pitting edema, or, they check their blood pressures and their heart rates themselves at home. So I have some vitals to assess. Phone visit, of course, is not as ideal for multiple reasons, but that is also another way to reach out to the patient and make sure at least symptomatically they're improving, and they can check their blood pressure at home and let us know what that looks like. But certainly there needs to be, we need to be very creative in how we reach the most patients that we can, especially those that can't make it to clinic.
I agree to all that. I think one thing to think about, we have this program called Periscope Project for Mental Health, where it's a provider-to-provider consult line. And so that might be something to think about down the road is, people in rural spaces. There's a huge push to keep people in rural spaces. So if we had even a consult line that we could help providers in those spaces, maybe could be helpful too.
Another fantastic resource, the Periscope Project, unique to Wisconsin. Okay, I'm going to wrap up now and respect everybody's time. I hope everyone has a great day, and thank you, Dr. Hoppe and Dr. Licon.
Thank you.
Thank you, everyone.